This is one forum, I always feel that everyone who attends the forum, everyone who comes to the particular webinar is the one who's really interested and takes away a lot of takeaway points. And thank you, madam, for giving me this particular opportunity to be speaking on the prescription writing. And I have tried to make it a case-based approach so that each one of us really understands what we need to do when we are seeing a patient of a particular condition. So we all know that it was in 1965 became available in UK. The WHI, 1965 that the HRT had first become available in UK. And we all know about the infamous WHI study, which had started in 1993. And it was stopped in 2002 because of increased risks of CVD, that is CVD incidents that had taken place, especially in the arm which was estrogen and progesterone. And that is when the mayhem started. And from 2003 onwards, we actually stopped using the HRT. To such an extent, the number of people who were using HRT had fallen down to 10 to 20% as compared to the ones using before this trial. Dr. Juan had once said this: the pendulum has swung so widely from hormone therapy that is good for all women to it's bad for all women. But today is the time when the pendulum has come to rest. And that is why, if you really see in the last 1 or 2 years, we've been having so many webinars and so many talks on the use of the MHT. In India, the MHT strikes very early. It's at 46.2 average years when women has got menopause. That means if we really take that the life expectancy of a woman at present in India is 71 years, she nearly spends 25 years of her life in menopause, silently suffering from the deficiency of the estrogen and the menopausal distress. 70% of the women are known to have VMS. 33% really feel that the social life has taken a backseat. 45% struggle at work. I think you could hear me saying that 81% have low BMD and nearly 2 times increase in the CHD risk. That is what happens when a woman is in the menopause period. So today I'm trying to go through a case-based approach to dispel basically the fears and the myths that we all gynecologists have about the MHT, and to understand what, when, why, and how of MHT. So it's the first case we're talking about is Priya. She's a woman of 46 years of age. She's having periods every 3 to 4 months for the last 1 year. She's not bothered by the fact that the periods are irregular, but the fact that she's unable to sleep at night, she's having hot flashes, and she gets very easily irritated at work and is depressed. She has been to several gynecologists and all of them have told her, this will pass, wait, your periods will stop and things will become better. She's a non-smoker with no medical problems and her BMI is 26. So if we really say that what is phase of menopause she is, and she's in the perimenopause or what we refer to as a menopause transition. Question is, can we confirm it? What do I advise her to relieve her symptoms and what options do we really have? So it's very clear that we actually do not need to do an FSH to make a diagnosis. There was a SWAN study which clearly stated that change in the menstrual patterns is a better predictor of menopausal stages than doing a serum FSH. But if the patient insists and you really want to reassure it, an FSH greater than 25 can suggest that yes, the woman is in the perimenopausal period. What are the options we have? The best option we have is a sequential MHT, which is 1 milligram of estrogen and 10 milligrams we are giving of dydrogesterone. Or we have got the low dose oral contraceptive pill. This can be more better in the women who want contraception or who are going to have heavy bleeding, for it tends to control the bleeding better. Sometimes women who have severe AUB, we can even put an LNG IUS and give them then orally estrogen. This will tend to also help them. Other options, when none of these patient is willing or she's not able to tolerate, then we have the SSRI. So this girl, Priya, she opted to go in for the low dose OC since she had not heard about the sequential MHT, and she's very comfortable. Now it's been nearly 3 years that she has been taking. She's 49 years of age, and she wants to know whether she should continue it or stop it. This is a dilemma which all of us tends to face, that a woman is reaching 50, she's on low dose OCPs, what do we do? So it is accepted that since our age of menopause is 46, between the age of 48 to 50, we can clearly shift from an OCP to a combined MHT. Other option is that we stop the OCPs, but we should do an FSH at least 7 days after taking the last pill. And if the FSH levels is more than 25, sometimes we say 30 or 40, then it is confirmed that she's in menopause, and we can move on to the combined pill, continuous therapy of the MHT. Which are the patients in this whom we prescribe in SSRI? In whom the estrogen is totally contraindicated, it is not well tolerated. For a woman who has stopped estrogen and then she has a relapse of the VMS symptoms and she does not want to restart the estrogen, or the women with VMS who have got depression. This is the category of patients where we can use SSRI. The only SSRIs which are approved by the US FDA, they are the paroxetine, citalopram, and escitalopram. Sertraline and fluoxetine are not recommended for the management of VMS because they are found to have no clinical benefit in these cases. The girls or the women who do have problems in sleeping at the night, gabapentin may be a better option, starting it at a slow dose of 100 milligrams at night, and we can slowly increase it up to 300 or maybe 900 sometimes to relieve the symptoms. For the women who are on tamoxifen, the ones who are breast cancer survivors, these are the ones where we cannot give estrogens, so then the drug of SSRI, that's venlafaxine, is considered to be the best to be given to them. And the dose is 37.5 milligrams per day for 1 week, and we can increase it depending upon the symptoms to 75 milligrams per day. Coming to the next patient, that's Anju. She's 48 years old. She presents to our clinic for the evaluation of hot flashes. Last year, she had been experiencing about 6 to 7 hot flashes per day. She often wakes up at night totally drenched in sweat. She feels fatigued and irritable most of the time. This woman has not had a periods for the last 2 years. That means she is postmenopausal. Anju thinks that she may be going through the change and wonders how long will this go on like this. So if you really see, 80% of the women, they tend to suffer from VMS symptoms, but only 20 to 30% actually seek medical attention. If you look at the duration that a woman suffers from VMS, the SWAN study has shown that the duration on an average is about 7.4 years. And that is a Penn ovarian aging study said that the mean duration is about 4.9 years, but some women, nearly 1/3 of the women, may tend to suffer from this for as long as 10 years after the final menstrual period. Anju says she's desperate for some type of relief from the hot flushes. She's a lawyer, experiences hot flushes during court, and it has become really very embarrassing. She has tried dressing in layers, avoiding hot beverages, keeping the room cool, but nothing seems to work. Her best friend was recently started on hormone therapy by her doctor, and she too now wants it. So what we need to consider is that what would we consider and evaluate before giving her the MHT. So first of all, does she fall into the right indications? There are 4 indications for which MHT can be easily prescribed. The most common, the bothersome VMS. The second is the genitourinary symptoms of menopause. The third, premature ovarian insufficiency, is mandatory. And the fourth is prevention of osteoporosis in those who are at high risk of developing osteoporosis. It is not recommended as a prevention of chronic diseases, whether it's CHT or osteoporosis, neither for improvement of the cognitive functions or the prevention of dementia. Who is an ideal woman to be started? The one who's healthy and has symptoms, that is a VMS, but she's within 10 years of menopause and less than 60 years of age. I think this is the most important point that we need to remember before we tend to start, that she should be less than 10 years of menopause and less than 60 years of age, and a woman who has got no contraindications. So if you look at this particular less than 40, where we define it as a premature ovarian insufficiency, MHT is mandatory till the natural age of menopause. Between 40 to 50 and 50 to 60, the benefits always exceed the risk, and more than 60, the risks are more, and hence MHT has not to be given. This is a wonderful table which had been published in NAM's 2020 guidelines. It clearly says that if a woman is less than 60, within 10 years of menopause, and she's found to be low risk for breast and cardiovascular disease, strongly recommended to have an MHT. We have to consider with caution if she's more than 60 years, or she's more than 10 years of menopause, or she has moderate breast and cardiovascular disease. And we definitely have to avoid it in those who are at high risk of breast or cardiovascular disease, or who are more than 60 years of age and more than 10 years of menopause and have moderate risk of breast cancer and cardiovascular disease. So here, two things we are clear is age as well as the years from menopause. The second two factors we have to look is the risk of breast cancer and the cardiovascular risk. Now, this girl, Anju, is a non-smoker, BMI 25. Her only medical problem is she's hypertensive, but it's well controlled. She's never had abnormal mammograms, breast biopsies, any gynecological surgeries. Her mother had a heart attack at the age of 65, and Anju's really worried about herself. Her third-degree relative had breast cancer. Now she wonders if she will taking MHT will significantly increase her risk of myocardial infarction or breast cancer. And thus we need to see that do we have any calculators before starting an MHT to assess her risks. So if you look at the Indian menopause guidelines, it clearly says that if she's been started less than 60 years of age or within 10 years of age, 10 years of menopause, the risk of CVD is not increased. But yes, we need to have these particular calculators. So we have one calculator which has been given by the American Heart Association. It's all mobile calculator where you need to fill the various aspects and it calculates your risk. And the risk that it tends to give is low risk if it is less than 5%, MHT is okay. Moderate, it's 5 to 10%. MHT is okay, but transdermal is better. And the risk is more than 10%. Then we need to avoid MHT. Our own IMS guidelines as well as the WHO has given this watercolor chart. It's a color-coded chart. It takes for both men as well as women, smokers, non-smokers. It has age at the baseline, blood pressure as well as the lipid profile. Based on these, we can calculate the risk. If she falls in the green, that is less than 5%, MHT is perfectly okay for her. If she's a yellow or the orange, which is considered to be a moderate risk, it's preferably to be transdermal. And if it is red or maroon, that she's in a higher risk, then it has not to be given. In case of those women where we do not have the levels in the sense that we do not have got the lipid profile, there they have used the BMI and they have calculated with the base of the BMI a similar color-coded chart based on which we can decide whether she's at a high risk of being given an MHT or she's at a low risk. The second risk we need to calculate is the breast risk. For the breast cancer risk, we have the Gale model or we have the BRCAT. This is again online model, though at present it has not been validated for India. But this definitely gives us the risk whether this particular woman should be given MHT or not. And the cutoffs are less than 1.67% MHT okay, between 1.67 to 5 caution, and more than 5 definitely we need to avoid. Thus, we have chosen our woman very carefully by estimating her risk of the breast, the cardiovascular, the age less than 60, as well as the menopause less than 10 years. And that is a woman who is considered to be a regular candidate. If you go on to the IMS guidelines, we've got various other rating scores and risks assessments, which I will not be talking about, but which we can use for all the women who tend to come to our particular clinic. After discussing her risks with MHT and really reassuring that her risk is very low, Anju is eager to start. What investigations would we like to do and which MHT would we like to recommend? It's very important that we do not start off the MHT without evaluating the patient. Over here, the calculation of the BMI, the waist circumference, and a usual complete investigation, which includes a complete blood picture, urine, fasting blood sugar, lipid profile, thyroid investigations, as well as pap smear, which falls in the particular time to have a pap smear. A mammogram too would be recommended, as well as we need to get an ultrasound done for her to be able to see what is the endometrium and presence of any particular cysts. I would like to say that it is not mandatory to do a TVS or to do a pap smear, but this is an opportunity that we have, and we should be using this opportunity to carry out a complete examination before we tend to start her with MHT. Now, which MHT would we recommend? If you look at the regimes, this particular woman, she's postmenopausal. She's 2 years after the menopause. For her, it is the continuous combined HRT because she has a uterus. So continuous estrogen and progesterone is going to be given to her throughout. If the woman, the one that was the one before who was in the perimenopausal, such a woman requires a continuous sequential HRT where estrogen is given for 28 days and progesterone is added only in the last 14 days. For a woman who does not have a uterus, it is only estrogen which is given continuously for these. Now the question comes when we have to select an MHT. what is the estrogen and what is the progesterone that it should have. So if you look at the estrogens that are available, we have the 17-beta estradiol, we have estradiol valerate, and we have conjugated equine estrogen. So we have to look at the one that is the one most physiological, which has the least liver load. And this particular picture is self-explanatory, that 17-beta estradiol, which has got a minimal load of the liver, and if we can, then it is best to use this particular one. Otherwise, CEE or even estradiol can also be utilized. It's always advisable to start with a lower dose and increase it gradually, trying to maintain its symptoms. So if you're using 17-beta estradiol, we can start by 0.5 or 1 milligram, which is 1 milligram is equivalent to 0.6 to 5 milligrams of conjugated estrogen. And for the transdermal patch, it is equivalent to 0.05 milligrams of the transdermal patch. Now, which are the women who you would opt for giving a transdermal instead of an oral? It's the women with hyperlipidemia, who are at high risk of VT or stroke, the women who are anticonvulsants, and the ones who are have migraine with aura. Any woman who is at a high risk of stroke or for VT, such women are preferable to use transdermal and not the oral therapy. The second aspect is the progesterone. So which is the progesterone would we like to give? At present, it is oral micronized progesterone or dydrogesterone. If you remember, it was a VHI trial which had the MPA which had been used, which is a medroxyprogesterone acetate, and it was held responsible for the maximum risks that were associated at that particular time. And now with all the studies, it has been clearly showed that it's oral micronized progesterone or dydrogesterone is a progesterone that has to be used. They are effective for endometrial hyperplasia prevention, they're metabolic neutral, and do not increase the risk of breast cancer. The dose, if it is continuous combined, it is 100 milligrams of the micronized progesterone or 5 milligrams of dydrogesterone. If it is a sequential regime, then it is 10 milligrams of dydrogesterone or 200 milligrams of micronized progesterone given in the last 14 days. So these are the various combinations which we can make with estrogens and the progesterone, but we should know that now we have got a combined MHT in India, which has 17-beta estradiol plus dydrogesterone. So a woman needs to take a single tablet itself. If she's in a perimenopause or we have a POI, then the dose of estradiol has to be higher. So it is either 1 milligram or 2 milligrams in the POI patients. Dydrogesterone remains the same, 10 milligrams given in the last 14 days. If she's postmenopausal, we can start with a smaller dose of 0.5 milligrams of estradiol and 2.5 milligrams of dydrogesterone. If she's not well controlled as far as the symptoms are concerned, we can go to the higher dose of 1 milligram plus 5. So it's known as 1 by 10, 2 by 10, 1 by 5, or it is known as 0.5 by 2.5 milligram. And this is a diagrammatic virtual presentation of the same thing. So Anju starts using the combined continuous estrogen and progesterone oral treatment. She has tremendous relief and she's really, really thankful to you. But she comes back to you 3 months later. Now she complains of breast tenderness and spotting. How are we really going to manage her and how we're going to plan it further? So it's very common to have breast tenderness after we tend to start this. So if the patient does complain, we need to reduce the estrogen dose or we need to switch on to another progesterone preparation. We can also ask her to restrict salt intake, cut down on caffeine and chocolate, and sometimes even changing to tibolone may be very helpful in those who tend to have nostalgia on the conventional MHTs. Some women do have spotting also when we tend to start this particular continuous combined therapy. And we need to understand that this vaginal bleeding may take place for approximately 6 months. At this time, all we need to do is to reassure the patient. But if it persists beyond the 6 months, then we need to do a transvaginal scan, look at the endometrium, and endometrial biopsy remains the gold standard in such cases. How do we follow up these patients? After starting MHT, 1 month later, we call her back, ask her for the side effects, check her weight and blood pressure, recall her back after 6 months. Over here, we are going to call her for looking at the compliance. Is she taking it properly or not? And thereafter 6 months, and then we tend to call this woman annually. As far as the follow-up investigations are concerned, it's the routine blood, urine examination, blood sugar, lipid profile, pelvic ultrasound and mammography as per the screening protocol, pap smear too as per the screening protocol, but DEXA scan, that should preferably be done every 2 to 5 years, although it's optional, but it will be good to do to know what exactly is the status as far as osteoporosis is concerned. So this woman, breast pain spotting has been relieved. Now suddenly she comes back. She's scared about developing breast cancer and she now wants to stop the medication. How would we counsel her? And if she insists on stopping, how do we stop this particular drug? So this chart becomes very, very helpful in counseling a woman. Women are generally scared of developing breast cancer, but we need to tell her that the risk of breast cancer with MHD is no more than the general risk factors like obesity, sedentary life, use of COC, smoking, and alcohol. The women who are overweight more than 30, they have got 24 times higher cases as compared to a woman who's on a combined MHD. The risk of combined MHD, the risk of combined hormonal contraception, and that of one who tends to have 2 units of alcohol is nearly about the same. So this chart not only reassures us, but by this we can counsel the woman that when her risk is low, it does not increase the risk. We also need to counsel the woman that what are the benefits of MHD? We know it tends to relieve the VMS. We know it does for the genitourinary symptoms, but we also need to tell her that it reduces the risk of osteoporosis, it improves osteoarthritis, it reduces the CVD risk, the risk of diabetes, abdominal obesity, it prevents cognitive impairment, it reduces neurovascular macular lesions, it also reduces the risk of colorectal cancer as well as endometrial carcinoma. In the end, it improves quality of life. So these are the benefits which are a little hidden, which we don't speak of, but we need to tell the patient that MHD not only is meant for the VMS, but it also has got a lot of benefits which are hidden behind it. Now, as far as the duration of therapy, when do we need to stop it? It's normally recommended that not more than 5 years and not beyond 60 years. But the latest guidelines now do say that if a woman is very happy with the MHD, at the age of 60 years or more than 5 years, we can reassess the risks and then have a shared discussion with the woman if she wishes to continue using this particular therapy. In case we need to stop it, it has been seen that 40 to 50% of women stop MHD within 1 year and 65 to 75% within 2 years. When we need to stop it by stopping 1 pill per week. That instead of 7, then we give 6, after that 5, 4, 3, and then slowly stop. Otherwise, there's a return of the symptoms of the VMS. A little about Tibolone, which is now again available in the market. The Tibolone is very good for surgical menopause in the women who are taking estrogen replacement, but the VMS tends to be persistent. Despite estrogen replacement, they feel decreased well-being. The ones who have got acquired sexual desire dysfunction, and Tibolone for all these conditions is a very good alternative or can be used as a first one. So this is, again, the indications that when there's a problem with mood or libido, older women, family history of breast cancer, history of endometriosis and fibroids, and of course, as an ADVAC therapy with the GnRH analogs. The dose is 2.5 milligrams single daily dose. Adverse effects is nausea, there may be weight gain, increase in the recurrence of the breast cancer survivor. So that's one place we are not going to give it. We are not recommending it to anyone who's at a high risk of VT because it tends to increase the VT incidence. And very important point to be understood, Tibolone can only be given to postmenopausal women who are 1 year after the menopause. This is the drug we all are really waiting for. That's bezodaxifene 20 milligrams plus CE. It has very few side effects. It has high tissue selectivity, and this is one which tends to have a benefit as well as osteoporosis, even on the VMS symptoms. Now, coming to the third case, the condition that we all tend to see is a 51-year-old housewife, postmenopausal for 4 years, complains with a lot of vaginal dryness, local irritation, urinary incontinence, difficulty in sexual life. And on examination, we find that uterus as well, the vagina shows signs of atrophic vaginitis. How do we approach these? We need to understand that whenever it is a local problem, vaginal route of administration correlates best with improving the symptoms. We require a long-term treatment, and this treatment has to be started as early as possible. When we take VMS tends to decrease as the years post-menopause increases. But as far as the GSM or the VVA is concerned, it tends to increase as the number of years move away from the menopause. So this woman can be offered vaginal CE cream or the Osteor cream. The cream is 0.5 milligrams, is there in 0.5 grams. So we give it with an applicator, 0.5 grams daily for 2 to 3 weeks. Then we reduce it to 2-3 times a week and can be given easily up to 1 year. The CE cream, that's a Premarin cream. It contains 0.6 to 5 milligrams. And again, for that also, the dose is the same, 0.5 grams per day. The indications is, of course, we've talked about vaginal symptoms, that VVA, but women with recurrent UTI, they too tend to benefit with this, with overactive bladders. Even in the vaginal surgeries that we do pre and post, these have been found to be effective. And sometimes in the postmenopausal, it's very difficult to put in a speculum and take a pap smear. We can give them a short course and then call the patient after 15 days and be able to examine and take a pap smear. The important thing about here is that when a woman comes to you and you find that she has atrophic vaginitis, it's better to start the treatment early, because if you do not do it, then it becomes irrevocable changes which we will not be able to benefit this. These are the various ones that are available. We do have moisturizers and lubricants also. Lubricants are to be used only at the time of intercourse, but moisturizers can sometimes be used twice or 3 times a week, even before we tend to give the hormonal therapy, especially women who are reluctant to take the hormonal therapy. Now, this woman wants to continue. The question is, how long can we give it and what are the advantages? This can be given as long as one woman wants. We have the clinical data up to 1 year, but it is considered that if you want to give it for longer periods, there's no problem. We need to inform her that symptoms will come back when the treatment is stopped. This can be given to women on systemic ET is contraindicated. Adverse effects are extremely rare. We do not need to give any progesterone for the endometrial protection. Does she require any surveillance? No surveillance is needed. We do not need to do TVS to find out what the endometrial thickness is, unless and until a woman comes to us with unscheduled bleeding. In women who are breast cancer survivors, only after discussion with the oncologist. This is one that can be given, but only after discussion with an oncologist. Coming to the next case, that is a 53-year-old postmenopausal. She comes with dyspareunia and loss of interest in sexual function. It's very important, when such a woman is sitting, we need to really ask her, because there was a study in which people said that the practitioner never asked us this problem, so we did not open it up. So it's important for us to ask that, do they have this particular problem? And we will be surprised that many women do come forward to us with this particular problem. So for sexual function, transdermal estrogens are considered better than oral estrogen. It tends to improve the libido as well as the sexual function. The dose is about, if we do have this gel, we do not have patches, but we can give it 0.025 milligrams per day, once a week. Vaginal estrogens, we do not have the vaginal estrogens, but yes, the tubes that we're talking, the creams, they will affect the VVA, but they do not have a direct effect upon the libido. But tibolone is an extremely good drug, which we can give them as a first-line treatment over here. We are really waiting for osmifene to come. That's a 60 milligrams oral tablet, which is very good for VVA as well as sexual dysfunctions. Even the intravaginal DHA, which is known by prasterone, 6.5 milligrams suppository cream is there. The 2 drugs, we are really waiting for them to come to India for us to be able to use it. But yes, testosterone also, transdermal and intravaginal gels, they can be utilized. We do not have one that is specifically for the postmenopausal, though we do have the androgel. And that can be utilized at much less doses in case it is needed. And that's the last case, that's of premature ovarian insufficiency. It's a 30-year-old woman, a girl who has come with secondary amenorrhea, 1 year, preceded by irregular periods coming once every 2 to 3 months. She's been married for 3 years. She's nulliparous, BP, weight, everything is fine. We did her UPT, it was negative. Investigations were done to rule out tuberculosis, TSH, prolactin was normal, progesterone challenge was done, that was negative. But then when we gave her estrogen progesterone, it came out to be positive. So of course, FSH LH was done, and that clearly showed that she is in premature ovarian insufficiency. So such a girl, we really need to have a holistic approach. She's got several problems. She has fertility issues. We have to talk about hormonal health, about her long-term bone health. She requires a lot of emotional support. And also we need to further investigate her for autoimmune endocrinopathies. Here I should only be talking about the hormonal therapy that we need to give. As I've already stated before, in these cases, it is mandatory. I would use the word mandatory to give these particular women a hormonal therapy. Estrogen plus progesterone. Here the estrogen dose has to be higher as compared to the other MHT. It's 2 milligrams. Plus dydrogesterone, that's 10 milligrams, which has been given for the last 14 days. It's available as Femistone 2x10, or we can give a combined sequential regime. The age till which we have to give is still the normal age of menopause, that is till the age of 46 years. They do always have an option of being given as COC over here, but if we really compare the two things, COC is very good because it provides contraception. Because in these women, we can have some ovulation and they can become pregnant. But if you look at the one which is more physiological, the one which is better for the lumbar spine, it is found that the MHT is the one that is better. So I would like to say over here that early initiation of MHT is very important because it increases the risk of CHT, fracture, as well as all-cause mortality. It reduces the osteoporosis and fracture risk, 48% reduction in CHT risk, 30% reduction in all-cause mortality. One size doesn't fit all women when it comes to treating with menopause. HRT must be individualized based on women's age, the time of onset of menopause, other cardiovascular, metabolic, and genetic factors. Just to summarize, if she has a surgical menopause, it's only the estrogen which has to be given, or we can give her tibolone. Perimenopausal, it is the combined sequential regime that has to be given to the one, or the OCPs. Early menopause, which we mean to say by the age of 40 to 46 years, or we would say that's the age. There again, EPT is found to be much more benefit. That's a sequential EPT should be given. And late menopause, that is more than 12 years, it is a continuous combined EPT, or we can give her a tibolone. So these two little cats are saying having 9 lives is cool, but if I have to go through menopause, let's forget this life itself is enough. And we would like to age like these wonderful 4 women. And that's the way we will, and we should help everyone by giving MHT where and when needed by removing our fears. So thank you so much.